All right, we're going to start. This is my talk on acute heart failure. I gave this talk a couple years ago, so some of the third years have seen this before, although it has been updated and hopefully improved a little bit. So I use the term acute heart failure. Many people use the term CHF exacerbation. Basically means the same thing. I prefer acute heart failure because a lot of acute heart failure is not congestive. Sometimes it's cardiogenic shock and hypoperfusing. But anyways, beyond terminology, we're going to get right into this about evidence-based management of acute heart failure. So as usual, we'll have a case to help guide this. So I've heard not everybody drinks alcohol or smokes cigars. So I've brought into my prize. This is an Amazon gift card, only $10, but still. Anybody want to volunteer? Not a third year, intern or a second year to solve this case? Yeah, Glenn. Very good, man. All right, so here you go. Here's your case. HPI, 72-year-old male. Has a history of hypertension. He presented to the ED with worsening shortness of breath and orthopnea for 3 days. He reports a dry cough and new leg swelling. He has no fever, chest pain, or abdominal pain. His only known medical problem is hypertension. He takes hydrochlorothiazide. He has no allergies. He smokes but doesn't drink or use drugs. This is not a trick. This is a talk about acute heart failure. But is there anything else that you want to know as far as history, though? All right, sounds like you've got all the information you need. Family history, nothing pertinent. All right, we're going to move on. Here's your physical exam. The abnormals are in red. So he's tachycardic, heart rate's 132, he's hypertensive, his blood pressure is over 190, respiratory rate's 24, and he's hypoxic with 88% room air sat. He's in respiratory distress. You listen to his lungs, he has crackles, and he has accessory muscle use. Listen to his heart, and he's tachycardic and irregularly irregular. You don't hear a murmur. Abdomen is a little tender in the right upper quadrant, but non-distended. His extremities show 2+ pitting edema in the legs. You got that more or less committed to memory, Glenn? Okay. So, question is, what diagnostic tests are you going to order on this patient? Only diagnostic tests. We'll go to treatment later. Chest X-ray, EKG.
Chest X-ray, EKG, CBC, CMP.
CBC, CMP.
BNP or pro-BNP.
Okay, pro-BNP. Anybody else want to order something other than a chest X-ray, EKG, CBC, CMP? All right, that's not an order, but you want to do a bedside ultrasound, Amr. Okay. What's that? So you want to test this patient for pulmonary embolism, even though I told you that this was a acute heart failure talk. Okay. All right. So that's actually a good discussion. We're not going to get into that in great detail, but if somebody has a classic heart, I tried to give this a classic heart failure presentation. Okay. If someone has that, even if they're not PERC negative and they're hypoxic, you probably don't need to test them for pulmonary embolism. Okay. But all right, you wanted to do some form of PE testing. That might be reasonable. I probably wouldn't in this patient. Okay. How about troponin? You didn't say that. I would probably get troponin in this patient. I think that's about it. Anybody else have any other things that they would do? But I like the bedside ultrasound. That's a good one. Yeah, exactly. Bedside echo. Bedside echo. Yeah, beautiful. All right, very good. I think those are reasonable diagnostic tests to start with. So let's go through some of those things. So here's the EKG that you got when you did an EKG on this patient, Glenn. So give me a under 1 minute interpretation of this EKG.
So tachycardic, it's irregular rhythm, irregularly irregular. Don't see like P waves in front of every QRS.
So what's that called?
AFib.
Okay. Yeah, so good. That's the main key here, is that this patient has atrial fibrillation with tachycardia, atrial fibrillation with RVR. And there's no major acute ischemic changes. There's a T-wave inversion in lead 3, but isolated, or actually with AVL too, but that's probably nothing to get too excited about. There's no STEMI. But AFib with RVR, that's the main finding on this EKG. All right, here's a chest x-ray. In the interest of time, I'm just going to tell you that what you see here is cardiomegaly. You see some perihilar fullness, suggestive of pulmonary vascular congestion, and sort of increased interstitial opacities everywhere to suggest pulmonary edema. So everything here so far is suggesting acute heart failure and AFib with RVR. So in general, chest x-rays for acute heart failure have can have four main features. Glenn, any idea what those four features on a chest x-ray that might suggest acute heart failure are? Cardiomegaly is one. Yep. Venous congestion, perihilar fullness. Yep.
Pulmonary edema, so I can't see the lung bases.
Okay. Interstitial opacities from pulmonary edema. And there's one more, and that's actually the three that you'll most commonly see. But if someone has more of a subacute or chronic presentation, so that's very similar to interstitial opacities. Yeah. So think of a more discrete collection of fluid. Pleural effusions. Okay, there you go. So this is sort of your med student level knowledge of what you would expect to see on a chest x-ray. But actually the key here is not that these are what you're going to see, but rather that chest x-ray is actually not terribly good for diagnosing acute heart failure. And at least according to this article from JAMA in 2005, 20% of chest x-rays have 0 out of 4 of these features, even though the patient still has acute heart failure. All right, so chest x-ray, not that great. A separate study that was published in 2017 quoted sensitivity 74%, specificity 86% for chest x-ray. So two different citations, two slightly different pieces of information, both telling you that you can have a normal chest x-ray and still have acute heart failure. And here the specificity, what this basically means is about 1 out of 6 patients who look like maybe they have heart failure on chest x-ray don't actually have acute heart failure. And you'll often see that with like a bilateral interstitial pneumonia. Or you may see that if someone just actually has a poor inspiratory effort, it causes more vascular crowding, and it may get read as interstitial edema, pulmonary edema, when it's actually not. So if chest x-ray is sort of mediocre or decent but not excellent for acute heart failure, what other diagnostic tests would you do? And Mid-Poly mentioned this one, which is a good choice. So here is the ultrasound, bedside ultrasound for your patient. And here is the ultrasound for a normal patient for comparison. All right, I am not an ultrasound guru. Good, none of the ultrasound gurus are in the room, but I am an ultrasound user. I think many of you know that. I will use my ultrasound to guide my clinical management of a patient. And hopefully when you guys graduate, you'll feel comfortable doing the same. So sort of my dumbed down version of how to assess this bedside echo. If you look here at the mitral valve leaflet, it's not getting up even maybe halfway up towards this interventricular septum here. So I'm making an estimate of what's called the E-point septal separation. And that distance between as close as that valve gets and the interventricular septum should be less than 7 millimeters here. Just sort of eyeballing it, I don't measure it in general. I can tell you that this is a diminished ejection fraction. And then conversely, on the other side, you see that mitral valve leaflet slapping that interventricular septum, suggesting a relatively normal ejection fraction. So without doing any sort of fancy velocity time integral thing, I've gotten a general sense of what the patient's ejection fraction is. When you do a bedside echo, why not combine it with a bedside lung ultrasound, which is probably as good, maybe even better than chest x-ray. And so here on your patient, you see this. You see a few, maybe 3 or so B lines. Okay? B lines are, for those med students or interns, those long stripes coming down like this. And on your normal patient, you look at the lung and you see nothing. And of course, in a real patient, you should do probably 4 spots minimum, 2 on each lung. And it would be consistent with acute heart failure if you saw those B lines in all the areas. If you only saw them on one side, then you're thinking a unilateral process, maybe like pneumonia or something else. Questions about that? Oversimplified approach to bedside ultrasound for a patient like this? No. Good. All right. BNP. So you wanted to get a BNP for this patient. Reasonable decision. BNP, though, is a good example of a test that you really must understand if you want to use it correctly. Okay? So before getting into sort of the details of how to use the BNP, I just want to clear something up, which is that there's really 2 separate tests. There is a BNP and there's an N-terminal pro-BNP, or some people just say pro-BNP. Which one do we have at our facility? Pro-BNP. We have the pro-BNP. And they are slightly different, although both are designed to assess for acute heart failure. The BNP cutoff is 100. Don't worry about memorizing that. I'm just trying to show you that the pro-BNP cutoffs are different. And the reason that there are 3, 450 is the cutoff if the patient is less than 50. 900 is the cutoff if they're between 50 and 75. 1800 is the cutoff if they're greater than 75, meaning that the pro-BNP goes up naturally with age, so you have to age adjust it. Actually, the BNP also goes up naturally with age, just not as dramatically, such that you could potentially use the BNP by itself with the fixed cutoff. When you are deciding to use a test, one thing that you guys unfortunately don't consider that much, and most people in medicine don't consider that much, but should, is the cost of a test. So at our facility, a pro-BNP costs $632. That is not a CT scan, it's not in the thousands range, but that's a substantial amount of money to just willy-nilly order. So before you order it, you should consider if you really need that test at all. When considering if you need that test at all, you should consider, as always, the test characteristics, or the sensitivity and specificity. The exact numbers here are going to vary depending on what source you look at, but I found for the BNP a sensitivity of 90% and a specificity of 76% when using that 100, that cutoff of 100. That's based upon an article from New England Journal of Medicine in 2002. On the other hand, the pro-BNP has a sensitivity very similar, 90%, but the specificity is maybe a little bit better at 84%. And that's based upon data from a study from the European Heart Journal in 2006. So while there are not studies, to my knowledge, that directly compare the clinical utility of BNP to pro-BNP, based upon the literature that I have seen, they're relatively similar. If anything, the pro-BNP is slightly more specific. But recognize that the specificity on both is sort of in the decent range, but not great or excellent range. And that is, in general, the problem with BNP or pro-BNP, which is too many things can increase either the BNP or the pro-BNP. And here is a list that is not all inclusive of some of the things that can increase these other than just acute heart failure. Number 1, age. I already said that the age will naturally increase both the BNP and pro-BNP. Gender. Females tend to have higher BNPs or pro-BNPs than males. Overweight people typically actually have lower BNPs or pro-BNPs. People who have renal failure have high BNPs or pro-BNPs. And in fact, if you have an end-stage renal disease patient, it's a little bit of my pet peeve, a BNP or pro-BNP is like completely useless in that patient. All right? It's always high. It has no utility at all. And if it's high, it doesn't mean the patient has acute heart failure. All right? So I never order, if someone has end-stage renal disease, a BNP or pro-BNP. All right. Pulmonary hypertension and PE for sort of the same reasons. If you're kind of causing some ventricular stretch due to that increased pressure in the pulmonary vasculature, then you can get an increased BNP. This is a great one here. Sepsis. So I see a lot of people and they order a BNP in a septic patient, hoping they can distinguish if they're acute heart failure or sepsis. That doesn't work very well. The reason is that in sepsis, for some weird reason, maybe it's some sepsis-induced cardiac dysfunction, your BNP goes up. And just because your BNP is up in sepsis doesn't mean you shouldn't fluid resuscitate them. So if you want to just not confuse yourself, just don't order a BNP at all in a septic patient. That's just kind of a dumb thing to do. The last one, AFib. So AFib, in the case at hand, is associated with acute heart failure. So there's kind of multiple reasons why the BNP might go up. But AFib on its own may cause an increase in the BNP. So the point here being that there are lots of things other than just acute heart failure that can increase the BNP. Clemens. Right, that's actually a great question. So that gets to the last point I'm about to make. So the question is for the microphone, if the patient had sort of a pneumonia versus heart failure presentation, would I get a BNP? And the answer is, depends on exactly what the presentation is. If they're like febrile and clearly septic, no. But if they're like not showing an infectious syndrome and they have sort of like mild bilateral opacities, probably yes, I would get a BNP. All right. So because this gets to the main thing is, when do you use the BNP, if ever? So should you use it at all? And I would tell you that the answer to that question is, I think, yes, but selectively. There are some people who are in the camp of never order a BNP or pro-BNP because you don't need it because you can figure everything out without it. There's some truth to that. And then there's some people who order a BNP or pro-BNP on like every single patient with shortness of breath, and I think that's also wrong. So when you are looking at the data as to whether or not BNP actually helps, there is some data that suggests it increases your diagnostic accuracy. However, data doesn't show it actually improves any clinical outcome. And in particular, a study from Annals of Internal Medicine published in 2009, randomized trial, took over 600 patients with shortness of breath. They randomized them to either BNP or no BNP. That was it. And they found the exact same outcomes and the exact same management for the patients, meaning that ordering a BNP on all your dyspnea patients doesn't improve any clinical outcomes. So I think that the real role of BNP is narrow, and it is to help on a patient who has an intermediate probability of having acute heart failure, meaning it's a presentation where maybe it's acute heart failure, but you're not entirely sure. If you have a patient who has no real symptoms to suggest that they have acute heart failure, like they're there for abdominal pain, absolutely don't order a BNP. I've seen people order a BNP on abdominal pain because the patient has a history of CHF and they just want to check the status of their CHF. That is not good. Do not do that. If the patient, though, has like some dyspnea and some little opacities, bilateral lungs, and you can't distinguish with your chest x-ray and your bedside ultrasound, that's not a bad patient to get a BNP on, so go ahead and get that. Now, just as I said that if someone has like no chance of having acute heart failure, you shouldn't get a BNP. Same thing goes if they have a super high chance of having acute heart failure. If they have every single symptom and sign of acute heart failure, you get a BNP and it's normal, guess what? The sensitivity is only 90%. So they still probably have acute heart failure. So you probably don't need to get a BNP on the slam dunk case of acute heart failure, nor on the case where the chance is very low. So it's hard to tell you exactly which cases you should do it. That's going to take time, and you're going to see variability in practice. But in general, the approach is it's somebody with an intermediate chance of having acute heart failure. That's the person that you want to order it on. And even doing so may not actually really make that much difference to the patient's outcome, but it may increase your diagnostic certainty. Questions about that? Nope. All right, very good. Let's go back to the case, Glenn. You've been off the hook for a little while. Let's get you back on. Here are your lab results in the interest of time, I'll say the CBC is normal for you. Just out of curiosity, you want to tell me some sort of interpretation of what do you make of these abnormalities in the metabolic panel, the LFTs? He was not, okay. He was not diuresed prior to this. All right, so let me get more specific to you. Let me get some more specific questions for you, because you're not catching on. Hyponatremia in the setting of acute heart failure. Common issue, not a common issue, signify anything? Relatively common issue, okay? If you admit a bunch of patients with acute heart failure, I don't know the exact percent, but a fair number of them are going to have hyponatremia. It's a relatively common issue that can occur. A hypervolemic hyponatremia is something that happens sometimes in acute heart failure, so that's expected. The potassium is actually not a little less expected to have hypokalemia in this situation, but he's on hydrochlorothiazide chronically, so perhaps that's the reason he has a little bit of hypokalemia. Any idea why this is going to be relevant here when normally I could care less about a potassium at 3.3? When normally I wouldn't care about it. All right, yeah, so if you're going to give this guy Lasix, furosemide, that's going to drop their potassium. So you probably don't want to give someone a medicine that drops the potassium and someone who starts with a low potassium. So if you're going to do that, you should probably give this patient some potassium before doing that. Now, okay, renal insufficiency here. So this is a common issue. So the question is, would you still be okay with diuresing this patient, or do we need to give him fluids because of his renal insufficiency? He has renal insufficiency, Glenn. Yeah. All right. So this is a common thing. I don't know why people come up with this, that you shouldn't diurese someone if they have renal insufficiency. But if they have renal insufficiency because they're in acute heart failure, the treatment for their renal insufficiency is not fluids, it's diuresis. All right? You diurese them and their renal function will improve. All right. LFT abnormalities. Glenn. Boom, that's the exact fancy words, congestive hepatopathy. Very common to see some abnormal LFTs in a patient who's in acute heart failure because the fluid backs up into the liver. And if you noticed on the physical exam, there was a trap in there to try to see if you were going to work up their abdominal tenderness. In this physical exam I showed you, the patient had mild right upper quadrant tenderness. That's actually quite common. If you do a thorough exam on a patient with acute heart failure, they'll have a little tenderness on their liver, and that's because of congestive hepatopathy. Now, they're not complaining of abdominal pain, and they're there for shortness of breath. Don't chase that. Don't chase that. Just leave that alone. That's expected finding in acute heart failure. All right, very good. Let's move on. So now is your chance, Glenn, to tell me what treatments you're going to initiate on this patient. Okay, so when you say diuresis, specifically, what are you going to order in the computer? Furosemide. And PO, IV, drip, sublingual. I don't know if they make sublingual. I don't think so. PO furosemide, how much? Okay, that's all right. You're an intern. That's okay. Second or third year, I want to help. What's your normal dose of furosemide would you use on a patient like this? 40 milligrams IV, that's a reasonable dose. All right, we're going to talk about dosing of furosemide. All right, so in addition to furosemide and potassium, what else, if anything, would you do for this patient for as far as treatment? BiPAP, okay, good. And what would be your settings for BiPAP? Hard question for an intern, but 16/5? Interesting, okay. All right, okay, 16/5, and your FiO2? All right, so you've got, these are the treatments you've given me so far, BiPAP, furosemide, and potassium. Anything else? All right, this was for Glenn, Anton. All right, so how much nitro are you going to use, Anton?
I wouldn't put him on a drip because I'd send him to ICU.
You would not put him on a drip to avoid having to send him to ICU. Okay, interesting strategy. Not necessarily patient-centered strategy there, but okay. Systems-centered strategy. All right. So what dose of IV? You want to use IV nitro? What dose would you put the drip at? 200 micrograms per minute. Okay. All right. We'll talk about that. Sizable dose. All right. Pressure is 190. Systolic blood pressure is 190. Okay, all right. So a lot of things to clarify in that talk and what you guys just said. Okay, so in general, should you give furosemide for a patient with acute heart failure? And the answer here is yes, usually, but be careful. So the majority of your patients who you're admitting for acute heart failure, yeah, go ahead and give them a dose of IV furosemide before you admit them. But some patients with acute heart failure actually don't need furosemide and are not fluid overloaded. Example that would be easy to understand, patient who comes in and they have abrupt onset in chest pain and shortness of breath, they're having an MI, their blood pressure is like 85 because they're going into cardiogenic shock. Do you want to give furosemide to that patient? I don't. I would actually probably give them a small fluid bolus. They had the abrupt onset of their symptoms. It's very unlikely that they have accumulated too much fluid in their body at that point. I would actually give them a fluid bolus. So yes, probably the majority of heart failure patients you admit are fluid overloaded and can benefit from furosemide, but don't think 100% of all heart failure patients need furosemide. Most do, not all. Second, there are downsides to furosemide. You give it to the wrong person, it's probably harmful. If you accidentally give it to sepsis patient, that's not going to be good. That patient is going to have a worse outcome. So you want to make sure you give it to the right person. And finally, what I would say is that if you think that furosemide use is based on high quality evidence, you are incorrect. So there are actually no randomized trials that compare furosemide to placebo to suggest that furosemide is better than placebo. And at this point, furosemide is so ingrained in our medical culture, I don't think anyone's going to ever do that study. And that being said, since over 30 years ago, since at least 1985, there have been studies suggesting that maybe furosemide is not necessarily a good idea. And in fact, this is a kind of an interesting study from the Annals of Internal Medicine in 1985, where they took patients who had chronic heart failure without acute symptoms, and they gave them furosemide, and they measured a bunch of stuff with fancy catheters, and they found that actually the furosemide briefly decreased their cardiac index, the opposite of what you want. And that's because it had some increase in the afterload effect. It had some sort of weird vasoconstrictive effect, increasing the afterload. And the author said, maybe we should not be giving furosemide for heart failure. But nobody listened to them, and so we still give furosemide to heart failure all the time. Another interesting study about furosemide was published in Chest in 1987 by Jerry Hoffman, a big name in emergency medicine. And in that study, they randomized patients in the pre-hospital setting to some combinations of furosemide, nitro, and morphine. And what they found was the patients in the nitro groups had the best outcomes, and in the furosemide groups, while not statistically significant, had trends towards worse outcomes. From which they concluded that nitro is really the optimal treatment for acute heart failure, furosemide less so. I also conclude from this study that you should not be giving furosemide in the pre-hospital setting. And I think it's crazy that in some pre-hospital settings, that is a medicine. So it takes 30 minutes to start diuresing a patient, and you give it to the wrong patient, it's harmful. So that's just my opinion. So you decide, though, that you're going to give furosemide because you believe that getting some of the fluid off is a good idea. And for a lot of the patients, it probably is, despite the minimal amount of randomized trial evidence to suggest the benefit of furosemide. The question is then, how are you going to dose it? First question is, are you going to give a bolus or a drip? Nobody here said drip. So I assume that you already know that you should use a bolus, but on some of my inpatient rotations in med school and in residency, some people were still giving drips. So is it actually better to give a drip? And this has been well studied, and the best study was in the New England Journal of Medicine in 2011. They randomized patients with acute heart failure to either a bolus with 2 separate doses that I'll get into in a second, or a drip of furosemide. And the bolus versus drip outcomes were identical, meaning that there is no benefit of putting a patient on a furosemide drip. So continue doing what you have been doing. If you didn't even know that a drip was a possibility for furosemide, good. Maybe I shouldn't have mentioned this at all. All right, so never need to use a drip. The outcomes are just as good with a bolus, but a drip is more expensive, more complicated to set up. So bolus dosing is fine. Once you decide you're going to give a bolus of furosemide, the question is, what is the dose? There is a little bit of variation in this, but the best data actually comes from the same study that I just mentioned from New England Journal of Medicine in 2011. And in that study, they randomized patients to either 1 times their daily dose orally. So in other words, they took 40 milligrams at home PO daily. They would give them 40 milligrams IV. That's how that worked. Or they gave them 2.5 times their home daily dose. So if they took 40 PO at home, they'd give them 100 milligrams IV. And when they split those two groups up, what did they find? They found that if you use the higher dose, the 2.5, you get a little bit better diuresis, a little bit more weight loss, but it comes at the cost of a little bit more acute kidney injury associated with sort of over-diuresis. So in my opinion, the range anywhere in the 1 to 2.5 times the home dose is a reasonable amount, recognizing that at the lower end, you're going to get a little bit less harm, but in the higher end, you might get a little bit more diuresis. And my personal practice is generally to do the lower end, just to do their home dose, but given IV. You can always give more, but you can't take it away. If the patient doesn't have a home dose, 20 to 40 milligrams IV would be reasonable. I usually do 40. Questions about furosemide dosing? No. All right. So I'm going to run through this quickly. So there was a study that came out in 2017 that found retrospectively that the sooner that you give furosemide, the less mortality there is, meaning kind of like the sepsis antibiotics nonsense, that the faster you give it, the better. However, this is extremely limited because as with any sort of time study done retrospectively, the more complex patients are going to have delays to initiating their treatment, or there was other reasons that their treatment got delayed, which is likely explains why their mortality is worse. So I don't think at all this should ever be a metric. If somebody tries to make a door to furosemide time a metric, I'm going to throw a stink. And in fact, not only is that study garbage, well, garbage is excessive, but probably incorrect, making the incorrect conclusion. There's other studies that show the exact opposite. This is a study done the next year. The other study was done in 2017. This one was done in 2018. This one found no difference in early versus later furosemide. It is my opinion that you should wait to give the furosemide until you are very certain you're dealing with acute heart failure and not pneumonia or PE or something else. So I will often put the patient on non-invasive positive pressure ventilation, maybe give them nitro, and then hold off on the furosemide for a minute, make sure I have my data that confirms that my suspicion of acute heart failure is correct, and then administer the furosemide, because that is a medicine that could cause harm if you give it to the wrong person. All right, nitrates for acute heart failure. Should you give them? In short, yes, you should give them. I already talked about one study in the pre-hospital setting that found that nitrates were probably better than furosemide for acute heart failure. And there's a whole bunch of other studies that show that they're at least as good as furosemide, maybe better. So I recommend that you use IV nitrates or nitrates of other sorts, we'll talk about that in a second, fairly liberally in a patient with acute heart failure as long as they have a normal to high blood pressure or a high blood pressure, right? If you start with a normal low or low blood pressure and you give someone nitrates, that's probably a bad idea. And that patient's probably going to become hypotensive and you're going to make them worse. So I'm looking for two things before I initiate the nitrates. One is a decent blood pressure, normal to high or high. And I'm looking for some respiratory distress, because if the patient is just chilling there completely fine, they probably don't need nitrates either. If you gave that person nitrates, because their blood pressure was high, be okay, but it's probably just unnecessary. High-dose nitrates are something that are talked about in a lot of podcasts and blogs, so I thought I would mention it briefly to talk about the evidence for it. Anybody heard on MRAP to use the super high, like Spencer level dose of? Yeah. So this is interesting. So I've heard those. I listened to all those podcasts as well, and I got to tell you that unfortunately that's not based on strong evidence. So there's actually no studies at all that look at that high dose and compare it to anything else. And the study that's often cited when on the blogs and podcasts is a study from Annals of Emergency Medicine 2007, which actually didn't use high dose drip. It used a lower dose drip, but used with the low dose drip large boluses. They would give the drip running at a lower dose, and they would give 2 milligrams at a time of nitroglycerin in addition to the drip. So that was a high dose, but it wasn't the high dose drip. And that study didn't even have a control arm. So I'm surprised it wouldn't probably get published in Annals of Emergency Medicine anymore. In 2007, it was a little bit easier to publish there, but I doubt it would even get published today. So what I'm telling you is it may be that some patients benefit from that high dose drip, but that is not an evidence-based practice. There is not a single study, at least not a randomized trial, that suggests that that is better than starting the drip low and then titrating it up. And that's what I do. I started around 20, 25, and if they stay hypertensive, and if they stay like in respiratory distress, then I can go up, and I'm happy to go up to 100 micrograms per minute. But I don't personally think that that's a great evidence-based practice to start at the really high dose drip. Right. So what I'm saying is simply this. I'm not saying this doesn't work to put the patient on 100 micrograms per minute, but I'm saying as an educator of residents, I can't stand up here and tell you to, in an evidence-based talk, to use this strategy. It's not evidence-based. Not a single study, not a retrospective study, not a randomized trial study looks at this dose starting off of an IV nitro drip and finds a benefit. Not one. Can you use sublingual nitro? Can you use nitro paste? The answer is I will use some sublingual nitro. So remember, a sublingual nitro is 400 micrograms, so that's a nice solid bolus. And I kind of have a habit here, because it takes a while to get the nitro drip going, of giving them some sublingual nitro until it takes like 15, 20 minutes for that nitro drip to come so that they have some nitro on board. Alternatively, if you were trying to avoid a nitro drip altogether, you might get away with just giving them a little bit of nitro, a sublingual nitro alone, and trying not to give them anything else and just giving them furosemide and the sublingual nitro. You can do it. Nitro paste, my recommendation is not to use. I don't think that this should be a medicine that you should use for the following reasons. Number one, it takes about 45 minutes for it to take its effect. Why would you ever use that type of medicine in the ER when you have either sublingual or IV to give? Second, it has known erratic absorption. It's especially going to be erratic if the patient's all sweaty from having a severe acute heart failure exacerbation. So I don't think this should be a medicine you should reach for, except for maybe some really rare situation where you didn't have another type of nitro and the patient wasn't that sick. It definitely shouldn't be in the EMS protocols. That's just pure insanity. And medicine doesn't even take effect by the time they get into the hospital. So, all right, we're going to go on. This is the last bit here on non-invasive positive pressure ventilation. This is one of the most important, if not the most important, components of your management of acute heart failure patient. This definitely works. Patients were randomized in New England Journal of Medicine study in 1991. These patients had acute heart failure exacerbations that were severe. They were randomized them either to regular oxygen or to non-invasive positive pressure ventilation, in particular CPAP of 10. That's what they did. And they found that patients had less intubation. They found that patients had better hemodynamic improvement. They found a trend towards mortality benefit, but no definitive mortality benefit. So when should you use non-invasive positive pressure ventilation? Early and often on acute heart failure patients. And my recommendation is any working to breathe, any respiratory distress. All right, And then the last bit that I'm going to say, because we're out of time, this is a question of CPAP or BiPAP. So the answer is, when asked if you should use CPAP or BiPAP for acute heart failure, I would tell you that you could use either, but I personally like to use CPAP. So the landmark trial that was done in New England Journal of Medicine in 1991, they used CPAP of 10. That was basically the strongest evidence we have to date that this is an effective strategy. So I use, generally, CPAP of 10. That being said, there are studies showing that BiPAP is also effective for acute heart failure. So you could use either, but recognize that the reason to use non-invasive positive pressure ventilation is because that PEEP increases your oxygenation and also increases your intrathoracic pressure, which decreases your preload. But the IPAP, the other number, other than the PEEP, doesn't really do anything. That number is there to help with ventilation, which acute heart failure is not a problem with ventilation. It's a problem with oxygenation and excess preload and afterload. So anyways, that's all I've got.